Thank you very much for inviting me to join this webinar today. Hopefully what I'm going to be doing is giving you a flavour for the secretion management techniques that are available from your therapist. And these are obviously essential in the preoperative phase so that you're familiar, or your child is familiar with those techniques, so that should you run into problems, you're aware of what's available for you, and hopefully what we've taught you is appropriate for the level of strength that you have. So could I have my next slide, please? So just to summarise, respiratory physiotherapy aims to improve secretion clearance. And the way that we do that is by utilising the changes in airflow. We want the airflow to go out more quickly to shear off the secretions, but also we want to provide the chest with and the lungs with more volume. We want to give it a deeper breath to be able to get the air out quicker. And what we hope this will do is decrease sputum plugging, and that will also help remove secretions that can contain bacteria and provide local inflammatory areas. And all of this to get rid of the phlegm and decrease the amount or the severity of the chest infection that may be occurring. My next slide, please. And of course, this is no different for patients with congenital muscular dystrophy or myotubular myopathy. And what we need to do is we need to look at our secretion management techniques and our cough augmentation techniques, and we need to apply the appropriate techniques depending on the degree and severity of respiratory muscle weakness, and they can be tailored to an individual. Next slide, please. So if we look at the sequelae of respiratory muscle weakness, what you may find is that you have a decreased ability to cough, simply because your inspiratory muscles are weak, along with your expiratory muscles that are weak. As I've already alluded to, because the respiratory muscle weakness, you may not be able to take a deep breath in, which means that you can't get behind the secretions to bring them higher up so that they can be coughed and cleared. Our previous two speakers have already talked about changes in chest wall compliance. And respiratory muscle weakness leads to, as we've already heard, a tightening of the intercostal muscles. The scoliosis can change the chest wall profile. And obviously what we want to do is, in order to clear the secretions, we want to have a good compliant chest. We want to be able to deliver a deep breath in and see chest wall movement so that we know that we can get behind the secretions. And if all of this is going on all at the same time, that can obviously predispose you to recurrent chest infections. And one of the key things about recurrent chest infections is that even a simple cold in a neuromuscular patient will cause a decrease in their inspiratory and their expiratory muscle strength. And that can tip you into a critical level where previously you might have been managing to clear your chest and cough fairly well, but because of the added effect of the cold, you tip slightly lower down into a more critical level. And we'll talk about the techniques that we can use to improve that. So next slide, please. So I'm going to start with a decreased ability to cough. And this is what a cough would normally look like. What you need is an inspiratory volume of between 80 and 90%. And you can see that this causes an inspiratory flow. So a nice big deep breath in. Next, if you could advance the slide, there's glottic closure, and this usually lasts for about 0.2 of a second. And we can assess glottic function quite easily by asking either yourself or your child to take a staccato E. So if you can go E, 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 there is going to be good glottic function, and we're going to get a good glottic closure. The glottic closure allows us to have an build-up of the intrathoracic pressure. If you can advance the slide for me, please. And what we have is, at that point, a good abdominal contraction, which causes the glottis to open, and you will see that we produce a peak cough flow. And if you can just point to the top of the peak, that's lovely. So that's our peak cough flow there. And a normal peak cough flow would expect to give anything over 6 litres per second. And if we times that up, that will be a critical value of anything greater than 360 litres per minute. Now, we just need to bear in mind that these values are roughly in an individual that's 8 to 12 years and above. In children younger than that, we need to look at reference values which have been published, and we can certainly provide those and link them to the website. But all in all, you'll see that there is an inspiratory component, as I said, a compression component, and the expiratory component. And the key thing is that when you cough, you will hear an audibility of that cough. And any techniques that we're doing, we're trying to improve the audibility and the strength of that cough, and we know that we're getting an improvement. And we can also look at those techniques that we're doing and measure them to see if we're getting an objective change from the peak cough flow value that the individual can produce. Next slide, please. So techniques that we can use on the inspiratory component can be using a long volume recruitment bag, which is shown in the slide here on the left. What this device is an ambu bag with a one-way valve that you can either give a deep breath in via a mouthpiece or a mask. So you give the individual a deep breath in, the valve closes, another deep breath in, the valve closes, and another deep breath in, basically increasing this inspiratory volume that you can see here. Other countries use different techniques. Some will use intermittent positive pressure breathing or the bird. And some countries will deliver a deeper breath in with the non-invasive ventilator or give it a deep breath in via one of the mechanical insufflation, exsufflation devices. If you can advance the slide for me. If the expiratory component is a problem, we can provide a manually assisted cough. And if you advance the slide again, if there's a component with both of these techniques, we can combine the techniques to further improve the cough strength. And if that fails to produce a good, effective cough, we can look at more technical devices in the form of mechanical insufflation, exsufflation. And I'll show you what that looks like in a moment. Next slide, please. One of the key questions that I get asked is, from a cough augmentation technique, what form of manually assisted cough produces the greatest change in peak cough flow? What is the best one to do? And a colleague of mine, Michel Toussaint, looked at this, and he showed that if you squeeze the thorax as well as the abdomen, you are going to get a greater change in the cough strength compared to just either squeezing the anterior or the front top component of the chest or the sides of the chest. So I think that that gives us a good idea of what manually assisted cough will help either yourself or it for those of you best. Can I have the next slide, please? And if those techniques fail and we fail to get an improvement in cough strength above a critical level of 160 litres per minute, we cannot get our inspiratory and our expiratory components to be stronger than that, what we consider is using mechanical insufflation, exsufflation devices. And what these devices, there are various different ones depending on which country you're listening in, and the pictures of the most popular devices are at the bottom of this slide. But all of these devices do the same thing. They provide a deep breath in by an insufflation, and they rapidly switch to negative pressure, increasing the expiratory airflow, which simulates what you will see with a cough. And they can produce passively up to 360 litres per minute, depending on the pressure settings that the device is put on. Can I have my next slide, please? There have been various different studies looking at which technique improves cough strength the most, and this is just one of them by John Bark, but they all say the same thing. If you look at your peak cough flow, and like I said, what we're looking for is it to be over 6 litres per minute. If you look at an unassisted cough in neuromuscular patients, it's relatively low. If you give a deep breath in by breath stacking with a lung volume recruitment bag, you can improve the cough strength further. If you do a manually assisted cough, as I've described by the thoracic and the abdominal assisted cough, you will also improve cough strength. What's not shown in this diagram here is if you combine the two, you would expect to have a further increase in your cough strength. And as I said, that if that fails to improve the cough strength so that the secretions can be cleared, you would consider using mechanical insufflation exsufflation. Next slide, please. So often we get asked what cough augmentation techniques work, and there is very little evidence in children and over which are the critical levels that we need to improve cough strength. And unfortunately the slide has been a little bit distorted, but what I'd like to highlight is the peak cough flow, or PCF part of it, that's highlighted in blue. So in a group of patients with ALS or motor neurone disease, a manually assisted cough that was taught when they were well, and these patients had a peak cough flow of 245 litres per minute, was sufficient to clear their secretions when they were unwell. Whereas if the peak cough flow was lower, at a more critical value, which is quoted of around about 160 litres per minute, these individuals needed to use mechanical insufflation exsufflation devices in order to clear their chest. And this fits very much with what I see in my clinical practice. The weaker that someone is, the more complex techniques that you will need to use. Whereas if the weakness is relatively mild, you might get away with just teaching breath stacking with a lung volume recruitment bag, or even very simply a manually assisted cough. Next slide, please. I often get asked whether it's actually worth teaching people with bulbar weakness cough augmentation techniques. And in my clinical practice, I find that this is appropriate. You should always try and see which cough augmentation technique works. And there is some evidence in mild to moderate bulbar patients that they benefit and that there are changes in peak cough flow for these patients, but it's not as great as an age-matched non-bulbar group. We and other groups have shown that if patients with neuromuscular disease are acutely unwell, treatment time in order to clear their secretions is decreased with the addition of mechanical insufflation exsufflation. And also there is less treatment failure, and treatment failure is whether a tracheostomy needed to be inserted or whether patients were intubated and ventilated transiently to get them over that episode. Next slide, please. Now, that's all very well us talking about cough, and if you could advance the slide for me, what you'll find is that cough will clear a certain area of the airways, and that part of the airways is very high up. And if the secretions are actually lower down, they're more towards the outside of the lungs. No matter what cough augmentation techniques you do, you're not actually getting the phlegm high enough, the sputum, the secretions high enough so that they can be cleared. So what we want to do is we want to look at if the secretions are lower down, what can we actually do for that? And the answer to that is there are lots of options. And if you can provide me with my next slide, we will move on to looking at that. Next slide, please. So at the start, I said that the aims of physiotherapy, respiratory physiotherapy, are to clear secretions. And the way that we do this is we provide a deeper breath in. And if you advance the slide, what you can see is a deep breath in tries to get behind the secretions by utilising these airway channels or these interconnections between the alveoli. So the air gets behind it, and as we passively breathe out, the green blob, the secretions, we would hope will go higher up. Next slide, please. This shows a wide range of techniques that are available to respiratory therapists and respiratory physiotherapists, and not all of them are appropriate for individuals with neuromuscular disease. So the next part of my talk is going to focus on what techniques are probably more useful for you. Next slide. We should always start at the beginning, and conventional treatment for respiratory therapy and physiotherapy is manual techniques. And this can be percussion, which is simply, as you can see on this picture, the cupped hand through a towel, patting the chest, aiming to knock off the secretions and move them higher up. It can be more effective if an individual can take a deep breath in, or we can look at ways of facilitating that. Other techniques that fit into conventional treatment are also shaking. So as you breathe out, you provide some shaking or vibrations to the chest wall. And if I could have my next slide, please. What this does is, if you look at the columns for during vibration and shaking, if you look at the expired tidal volumes, they're actually greater than what the patient does at rest. So with these techniques, particularly vibration and shaking more than clapping, you're increasing the airflow, or the speed of which the air is coming out of the chest. And if you remember at the start, I said that's one of the things that we want to achieve, because that shifts and shears off the secretions. Next slide, please. A key thing that we also find is that if someone is fatiguing and they're breathing very, very fast, what we can do is we can provide ventilatory support. And in the last discussion that was mentioned, because it can offload the work of breathing, and we can use the ventilator to assist with giving a deeper breath in. Conversely, if you're on non-invasive ventilation, we don't want to take you off to do airway clearance techniques. And the reason for that is shown quite nicely in this slide. The top graph looks at how fast an individual is breathing, and the bottom graph looks at the tidal volumes for how deep the breaths are. And you can see on the left-hand side, before the red arrow, that the respiratory rate, the speed of breathing is quite slow, and we're getting quite deep breaths in. At the point of the red arrow, the individual has been taken off their ventilatory support. And the effect of this is that due to the fact that they're fatigued, their respiratory rate, their breathing rate increases dramatically. And in order to sustain that fast breathing rate, they breathe very shallowly. And all of that is not going to help clearing secretions, because as I said, we need to be able to get air behind the secretions by giving a deeper breath in and also mobilizing them. So my take-home message is, if you have ventilatory support, that's fine, you can advance the next slide. If you have ventilatory support, you can use conventional treatment on non-invasive ventilation. It's just a continuation. And if, for example, you don't normally fatigue when you're well, but you're fatiguing if you're unwell, providing ventilatory support and doing simple airway clearance techniques can help to mobilize the secretions from the periphery and help them to come further higher up of the airways. Next slide, please. This has been shown to work very well in cystic fibrosis patients who have been given ventilatory support in order to offload the work of breathing. And in the top left-hand graph, we're looking at the average oxygen levels of these individuals with either standard treatment on the left-hand side or non-invasive ventilation on the right-hand side. And you can see that in the session where the cystic fibrosis patients had airway clearance on non-invasive ventilation, their average oxygen level was higher. And another indication in the bottom graph is the percentage of time their oxygen levels were less than 90%. And this is also lower if you provide non-invasive ventilation to assist treatment. If you advance the slide, there was also less decline if we look at our inspiratory muscle strength, which is the top right-hand graph. You can see in the left-hand portion of this graph, this is standard treatment off non-invasive ventilation, and in the right-hand portion on non-invasive ventilation. And there was no decline in the inspiratory muscle strength and below in the expiratory muscle strength, indicating that hopefully, as I described in the slide earlier, the provision of ventilatory support decreases the work of breathing and the effort to clear secretions in this group of patients. And this is something we certainly see in clinical practice. Next slide, please. If someone is at the more severe end of the spectrum and they're on non-invasive ventilation, there are other techniques the respiratory physiotherapist or physiotherapist can apply. And one of those is called autogenic drainage. I'm just going to briefly mention it because the technique is carried out on non-invasive ventilation, but the respiratory therapist or physiotherapist holds the chest wall in different positions. So there'll either be quite a tight squeeze, followed by a medium squeeze, followed by less of a squeeze. And what that does is it mobilizes the secretions at different lung volumes, so from the periphery to the larger airways, and helps get it high enough so that you can apply your cough augmentation techniques. And in an individual that finds it very difficult to comply or assist with treatment, this can be a very useful technique. Next slide, please. It's already been alluded to that intrapulmonary percussive ventilation and high-frequency chest wall oscillation can also benefit. Again, just so that you can see what happens, the top picture is a picture of an IPV device, an intrapulmonary percussive ventilation device. And if you look at what this does in the lungs, you can see on flow and volume that on the airflow trace, the individual is breathing in and out, which is where it's going up and down, but superimposed on this is this high frequency oscillation. And these vibrations within the lungs help to bump and mobilize the secretions towards the upper airways. And if you don't have that device, another option is to use an external vest or smart vest, which will, with or without the addition of non-invasive ventilation, depending on the individual, which also provides an external vibration to the chest wall and again mobilizes secretions towards the higher airways. Next slide, please. And there has been some evidence in neuromuscular patients in the one study at the top one that providing high-frequency chest wall oscillation decreased the amount of hospital admissions compared to a conventional treatment, so percussion and shaking. And that's likely because it was reported that the parents were more compliant with this technique. It's also been shown in different groups of patients, and not just neuromuscular patients, but to improve oxygenation by decreasing the amount of secretions that have been present within the airways in both the CLINI study and the TRUSTA study, the one below. And when we're looking at Duchenne muscular dystrophy patients in the Toussaint study, the second from last one, in those patients that always produce secretions, they've had a greater yield of sputum compared to a conventional form of treatment. Next slide, please. We've also discussed chest wall compliance in the previous two presentations, and I've just got one slide on this that I would like to go through. So if we can go to the next slide. So this is looking at a form of chest wall stretching, and I think that this is something that we need to be paying more attention to detail with in patients with neuromuscular disease and congenital muscular dystrophy. So this is from John Bark's work, and in this slide you can see an individual's vital capacity as time goes on. In the very bottom graph, the triangles, you can see their vital capacity declining. No, sorry, and the lower one, that's it. You can see vital capacity declining as time goes on. In the graph above, they have been taught to glossopharyngeal breathe, which provides some increase in vital capacity in a technique that can be quite difficult to learn. But more simply, you can improve a supported vital capacity by breath stacking, which you can see by the dark squares. This is a maximum insufflation capacity, and this is what I said that we can do with breath stacking with our lung volume recruitment bag. So we can give a breath in, it's held, breath in, held, breath in, hold. And what you can see is, despite the fact that the spontaneous vital capacity is falling off, and that would be an indication that because they're not able to take deeper breaths in, that you would expect that there would be some shortening of the muscles of the chest wall and the chest would be less compliant. We can actually get stretching and we can maintain some chest wall compliance with the addition of breath stacking with the lung volume recruitment bag, as seen here by the MIC, or the black squares. Next slide, please. Next slide. And we've talked about attention to detail as well by the previous two speakers, and I'm just going to add to that by looking at what can we do if someone, despite our best ability with all of the techniques that I've spoken about, continues to have recurrent chest infections. And my top tips are, obviously, we need to involve our speech and language therapy colleagues to look to see if there is a component of aspiration that we have missed, or that we can look at in a little bit further depth. We need to treat hypersalivation with hyoscine or glycopodium or any other agents that can make the secretions at a more tolerable level, so that they can either be swallowed or they're not having an overwhelming amount of fluid and oral secretions in the mouth. Obviously, good oral hygiene is essential. Vaccinations are key. We've already talked about patients that once they have been treated for nocturnal hypoventilation, the chest infections that they had before decreased. And this could be because hopefully we're opening up areas that may have been atelectic or have secretions stuck down there and cleared them. In patients with more severe disease that have been colonized or that have a chronic level of bacteria in their sputum, nebulized antibiotic therapy may be appropriate for them. And of course, we mustn't forget an anticipatory treatment protocol. So we've looked at what secretion clearance techniques work for the individual, and we have a plan of what to do if they tip into respiratory problems, or likewise if there are respiratory problems the whole time, that treatment plan is reviewed, assessed, and made sure that it's working well for the family and the individual. Next slide, please. So what I've been through is that the number of patients that I am seeing that require secretion management techniques is increasing because I'm being much more proactive about it. I'm assessing all patients to look at their cough strength and making a plan about what cough augmentation techniques will work for that individual if they become unwell. I'm also introducing them to secretion management techniques should they become unwell, so that they are familiar with these techniques. And as there has been a focus on surgery through today's webinar, all patients should be assessed pre-surgical procedures and taught the appropriate cough augmentation technique. And it's appropriate for some individuals to be familiarized with their treatments on non-invasive ventilation if we suspect that the techniques that we can provide conventionally are going to need to be carried out on non-invasive ventilation. So I'm going to finish there with my next slide and say thank you very much. And it's not snowing in the UK today, but it is very wet.
Hi, this is Mark D.A. I have two questions, if you'll take them. The first is for Dr. Saunani, and maybe with Dr. Chatwin's help, we can come up with an answer. The normal movement of the rib cage is described as a pump handle and bucket handle expansion. Do we know what best stretching or normal movements in individuals that are uninvolved create the best rib and chest expansion and range of motion improvements?
I'm not so sure I understand the question. Are you asking?
You cited before that the range of motion of the rib cage was imperative for keeping lung function. So do we know in those uninvolved patients what movements best achieve range of motion in the rib cage? So if we understand
Mark, are you referring to physical types of exercise, or?
Yes, exactly.
Okay.
So what arm movements, what truncal movements, what rib cage movements do we know in normals create the greatest expansion?
I'm not aware of any arm movements that will help provide that effectively. But unless Michelle has any ideas from a physical therapy standpoint.
It would seem to me that we want to understand the uninvolved people before we can even start to understand what the neuromuscular patients are going to be, how they're going to get involved.
I think preserving that range of motion is likely going to be met with, maintaining a certain amount of flexibility of the tissues between the ribs, flexibility at the joints where the ribs meet the vertebral bodies. So that's where I think maintaining
how do those maximal motions, how are they achieved in normals?
Normal children run, jump, and play and take these maximal deep breaths that stretch all these areas. And the problem we have is that children who are unable to do this are on the receiving end of this restriction. It seems something we take for granted when it happens so automatically that as we begin to recognize its importance, we now wonder, how important is it really that we try and preserve these?
The way that we attempt to preserve everything is looking at keeping individuals as straight as possible, preventing the scoliosis progressing, and obviously that's a time factor thing. We can do that for a bit, but we're looking at attention to detail when they're standing, if they're in their wheelchairs, and then looking at other techniques that can provide some form of stretching, which can be in the form of hydrotherapy or over gym balls, and just getting some passive stretching that doesn't cause any discomfort or problems, but is feasible to be done at home.
So I think Mark's question is in part asking whether there have been ever any studies of different forms of exercise and which form of exercise, perhaps with 3D imaging, would demonstrate during the active range of breathing that you get maximal kind of chest wall excursion. And I think
not only breathing in, but definitely like movements over the ball, like Michelle just mentioned. Mm-hmm. There have to be arm movements, truncal rotation movements. I think of yoga, and I think of, child's pose, good folds, things like that, those different movements. So if we understood that how in someone who's not involved can actually achieve maximal range of motion, then we can start to train the parents and those with disease sets how to achieve maximal range of motion, even though they're not able to run and to jump and to take maximum insulation.
Yeah, I think we just aren't there yet. But I agree with you. I think it's a great question.
Absolutely.
Michelle, I have a different question. Is there a universal training video that can demonstrate to parents these techniques that have been proven to work? So the percussion, the shaking, the manual cough assist. Is there a great universal training video that we can impart to those with those parents that are struggling at home?
There isn't a universal training video that I know of. I do training videos with parents so that they can individually train up their carers, remember techniques and refresh things. But unfortunately that isn't available at the moment for the general public, just from a consent point of view of the people that have taken part. But I do think that would be a good idea so people can see a flavour of what's available and also check that they're doing the right thing after they've been taught it down the line.
This is Sarah. I just wanted to mention, Mark, about your question about exercise training for, I know that I think Barbara Smith down at the University of Florida, Gainesville, is working on, she's doing a protocol now for people with neuromuscular disease. It's a respiratory training protocol, and she might be a good reference, and I can touch base with you about that later.
Thanks, Tracy.
This is Sarah again. I had a question about the cough assist, and what is the appropriate age? We use it very commonly here in the United States. I'm just wondering what age is appropriate to start introducing the cough assist?
In general? Yeah. Or is it specific to... Go ahead.
Just generally, when would it be appropriate to mention to families, especially for our community where patients with mild tubular myopathy have a onset of, respiratory difficulties at birth, et cetera?
It depends on the severity of the patient. So in individuals where secretions are a problem and it's relatively early in life and we're looking at perhaps that they've been in the intensive care environment for a reversible episode, then obviously I would discuss the use of the device then with the parents. But otherwise, if individuals are relatively well, their peak cough flow is very strong, I talk through, as I did in the presentation, the options of cough augmentation and when we start to introduce things so that they're aware that whatever we have taught is not just a ceiling of care, that if that's starting not to work and things have changed or someone's more acutely unwell and weaker, that there are other options available to them.
I have a question as well.
Go ahead.
Can you comment on the use of pulmozyme and the use of a saline solution in a nebulizer for children that have secretions that they're having difficulty getting up?
Do you want me to go for that one?
Go for it.
Okay. So we rarely use pulmozyme in any of our neuromuscular patients, except if we've got areas of consolidation that haven't been able to be cleared with saline nebulization, good hydration. So if we've got focal areas where there is secretion stuck and the secretions are very difficult to clear and we've adjusted any drying agents that they're on and we're still not clearing, then we use pulmozyme acutely, but not in the long-term situation.
I think we have to agree that on this side of the pond, we've taken a fairly similar stand. We've had some requests, but, you know, most often when a child comes in the hospital and there is a specific area that's opaque on an X-ray, any nebulized medication is going to go to the unaffected areas as well, and you don't know what it's going to do over there. So, periodically, if unfortunately a child was on a ventilator, I have instilled in specific areas of the lung some of these medications, but we don't routinely do it in a nebulized manner. I think the key is hydration, good airway clearance, hydration, good airway clearance.
I believe there was a case study of 3 cerebral palsy patients, if I remember this correctly, who had recurrent hospitalizations with pneumonia and prolonged hospital stay. And it was shown in those 3 patients, anecdotally, that pulmozyme shortened the length of their hospitalizations. But I think it's not definitely in by no means routine care for neuromuscular patients. This is Anna. I have a question for patients who either have a tracheostomy and are on ventilatory support overnight or are on non-invasive ventilatory support during the night and maybe also starting during the day. What is the role for cough augmentation devices during periods of wellness as a daily exercise routine?
I think it's invaluable. Oh, sorry, go ahead. I didn't realize. Is this from Michelle? Sorry.
Yeah, no, don't worry. I was going to say it depends on how much secretions are a problem, but I would always make sure that someone that goes through a regime at least once a day to ensure that the secretions haven't changed, the colour's not changed, as an assessment tool to see whether they will need to do more as the day goes on or seek potential review just in case the chest infection is brewing. But also, again, from a stretching point of view, it's also very good.
You know, I take a more practical stand with families, and I recommend that they do use it, even if there seems to be no need for it, a few times a week. And the reason, you know, I tell them to do that is you rather use it and know how to use it and the child know what to anticipate rather than initiate a whole new learning process in a crisis situation. It's better to use it and not need to use it than use it and wish you had practiced more. And the other thing is you also make sure. Sorry?
Yeah, I agree with you. People forget how to do the techniques.
You know, the simple things. Seals break, the hose develops a leak. It's nice to know that this is working effectively and you can change things or circuits need to be changed in a non-emergency situation, you never want to buzz it, wipe the dust off and say, oops, we need it, but the hose has a leak. It can certainly be very uncomfortable there.
For our older individuals who are on the call who are adults, is there a way of augmenting cough when one is quite weak or one also has contractures that can be done by the individual themselves, either using equipment or any other means in order to augment their cough by themselves?
You can use the lung volume recruitment bags. It may be that you need to have a longer piece of tubing so that depending on where the strength is, it may be that you can put them under arms and squeeze them a little bit, or some people are able to get them on the floor and squeeze them a little bit better with their feet, but you just need a longer piece of tube. And you can also practice bringing yourself forward at the end of it, almost to facilitate a manually assisted cough. So there are things that you can do by yourself. It just depends on the dexterity and the strength that you've got.
If I could just get some clarification on a couple of points. I am hearing that using a nebulized saline solution is a good starting point for helping to moisten and loosen the secretions. Is that true?
I don't routinely recommend that. Do you guys? Do you, Michelle or Anita?
We use it if secretions are a particular problem, but it's not in the majority of people.
Right.
And it's always on a trial to see whether it works. But the key things are making sure that people are appropriately hydrated. If anything, the key thing usually is the fact that they haven't added in humidification if they're using non-invasive ventilation for longer periods of time, or perhaps they need to adjust the doses of glycopyrrolate or hyoscine. It can be. It's more that issue than actually having to look at the saline. So we use it in some people, but it's not the majority of people.
What about the use of albuterol?
Shall I come in there? I certainly think that one might wish to use it in someone during a chest infection if they're wheezy. And so one would listen carefully, because some individuals develop, even if they haven't got asthma per se, they can get a bronchial irritability, a bronchial hyperresponsiveness with some chest infections. So I think that would be a good situation to use albuterol or the standard bronchodilators. But I don't use it, and I don't think there's a particular indication to use it in a preventative sense or in someone who there is not some kind of evidence of underlying asthma or this worsening of airway function at the time of a chest infection.
No, I concur.
I just remembered, I misspoke. I think the case report with the 3 cerebral palsy patients was for nebulized Toby and not for pulmozyme.
Yeah, that's what I seem to remember.
Yeah, exactly.
And, that was primarily because whenever we've done bronchoscopies in patients with these diagnoses, they usually have chronic aspiration and have, a fairly high load of oral flora in the lower airways, and I think that keeps the bacterial count down.
And I think, too, just to add that we have seen some cerebral palsy patients who, from their aspiration, have got an element of bronchiectasis, so they've got some chronic lung damage, they're colonized by Pseudomonas, and then Toby would work with them, which I think is less, we see far less frequently in the neuromuscular patients, pure, congenital neuromuscular patients. What I'd like to do is just provide a very brief kind of recap of the absolutely fantastic presentations and some of the discussion that we've had. So we initially started with a brief overview on how breathing happens both in people with and without neuromuscular disorders, with an importance placed on the chest wall shape and the impact of diaphragm involvement and the shape of the diaphragm, and a question regarding the role and the impact of scoliosis surgery on improving ventilation parameters. And then we
had a wonderful overview on what is respiratory management about in neuromuscular disorders, what is the role for proactive care, and how do we identify when there is a problem. That presentation delivered a very positive and strong message for proactive care, both in periods of wellness and when one is ill with a respiratory infection. And then we closed with a presentation that highlighted the incredible importance of cough augmentation devices and devices to manage secretions, again, also during periods of wellness and during periods when one is ill, and the need to potentially increase those techniques. Also, the individualization of those techniques depending both on the degree of weakness as well as the frequency of chest infections. I think some of the questions have highlighted the need for a universal training video, which I think would be exceedingly helpful for people with neuromuscular disorders, their caregivers, and parents and partners to see. And I really want to thank everybody for taking, in particular, our speakers, so much time on a Saturday morning or evening if you are in Europe or in the UK. For educating us on the role of respiratory involvement in neuromuscular disease. With that, I'd like to close and let people know that we will be placing the recording accessible on all of the advocacy websites. We will be drafting a transcript of the questions and answers. If there are additional questions, we didn't ask you this in advance, but could we potentially send additional questions to the three of you divvied up to provide us with some feedback on?
Sure.
That's
sure.
Fine.
Okay. If people have additional questions, if you would like to email them to Sarah Foy. Sarah, would you like to just provide your email address? If you can just speak it out so people know how to get in touch with you.
Sure. It's F as in Frank, O-Y-E, first name Sarah, S-A-R-A-H, @gmail.com.
And what we will do is we will collate all of the questions, divide them up, get answers, and then transcripts of those in addition to the questions that were asked will be placed on the website. If there are additional handouts, materials that you have found that are beneficial and you think might be helpful to people with neuromuscular disease, if you would like to send those to Sarah as well, and then we'll collate all of those materials and resources and broadcast those to the greater community. So again, a great thanks to Sarah as well as Wendy Hughes for really helping us pull this webinar together, and we look forward to the next webinar. Thank you so much and enjoy the rest of your Saturday.
Thank you.
Likewise.
Thank you.